Okay, so we're going to start with consequences of premature birth. Things that can happen if a baby is born prematurely. The disorders. First one we're going to talk about is respiratory distress syndrome. So respiratory distress syndrome for the baby is like the adult respiratory distress syndrome for the adult. Okay? For the babies, we just call it ODS. Okay? There are other names that the ODS is referred to as. They call it neonatal respiratory distress syndrome. So when they say that, they're also referring to ODS. Or maybe they can call it infant respiratory distress syndrome, or idiopathic respiratory distress syndrome. Okay. So we're also talking about all this. And then sometimes they can call it hyaline membrane disease. Okay, because of the scar tissues that form inside the lungs when babies have the ODS. So they call it hyaline membrane disease. So any of those names will suffice for ODS. Causes. Okay. The main cause, the predominant cause of ODS is prematurity. Okay. Babies don't have mature surfactants. Now, mature surfactant appears at the 35th week of gestation. That's when you have mature surfactants. So any baby that is born before then will likely develop ODS because they don't have enough surfactants to counteract the effect of surface tension. Maternal diabetes or gestational diabetes can cause a baby's lung to mature quicker before it is time for it to actually mature. Okay? So as a result of that, they can develop that ODS because their lungs are not really matured, they're prematurely mature. Okay? The next thing is cesarean section. Cesarean section. Now, the cesarean section is different because the baby doesn't go through the birth canal. The baby going through the birth canal during vaginal delivery is how most of the lung fluid is rid off. Okay? But because in C-section, the babies are not going through the normal birth canal, they tend to retain fluid at birth. Okay? And that is called, they develop RDS, we call it RDS, that too. Which is caused by retention of lung fluid at birth. There are some other causes, not just those two. Immaturity of the terminal air sacs usually causes poor gas exchange. Like I said before, the alveoli continue to multiply in number through the pediatric years. Okay? So they don't have enough alveoli for gas exchange. Immaturity of the chest wall. Okay, now the chest wall is used for inspiration. Okay, the external intercostal muscles are the muscles that cause the rib cage to go upwards during inspiration. So for the baby, their ribs are not very mature yet, so they don't have as much mechanical advantage moving their ribs away. So as a result of that, they develop retractions. They have to generate tremendous amount of inspiratory effort to try to breathe, which causes retractions. Their diaphragm is not fully developed yet. The diaphragm is one of the main respiratory muscles. And because of that, they go into distress as well. They may have apnea or prematurity. Okay, their central nervous system is not really matured yet. So now this central nervous system usually signals the diaphragm to contract for us to breathe. So with the baby not having mature central nervous system, that can also put them in distress. Pathogenesis. Okay, so decreased surfactant leads to high surface tension. Remember now, surface tension, what causes the starting tension to reduce is surfactants, mature surfactants. So they don't have mature surfactants. So the surface tension inside their lungs is always very high. So because of the high surface tension resulting from decrease in the level of surfactants, the baby's lung compliance will decrease. Their lungs get very stiff. Low lung compliance leads to atelectasis. Atelectasis leads to a poor VQ ratio resulting in hypoxia and low FRC. Now, VQ ratio is nothing but the amount of oxygen and the amount of carbon dioxide inside the lungs. When you have more oxygen inside the lungs than you have carbon dioxide, that is called a high VQ ratio. Okay? When you have less oxygen than carbon dioxide, you have low VQ ratio. Okay? With hypoxia, hypocarbia develops and leads to respiratory acidosis. Lack of oxygen at cellular level leads to metabolic acidosis. Alveolar capillaries and tissues are damaged due to hypoxia and acidosis. Surfactant production worsens due to the damage. Acidosis leads to pulmonary vasospasm, leading to pulmonary hypoperfusion. So the lungs are hypoperfused, they're not perfused enough. Hypoperfusion leads to a further worsening of VQ ratio and further hypoxemia. So this is like a vicious cycle. It goes all over and over, around and around with this pathogenesis. Clinical signs and diagnosis. Respiratory rate will be greater than 60 breaths per minute. Physical signs of respiratory distress. The baby will have grunting. So grunting is that noise that they make during exhalation. And what they're trying to do is to create PEEP inside their airway so that they can increase their oxygenation. That's why they grunt. They can also have retractions, which is where their skin is going to be moving inwards during inspiration as a result of increased airway resistance. They can have nasal flaring. They widen their nostrils and they tend to get more flow inside their lungs. The baby may have cyanosis if the baby is on remand. Diagnosis for RDS. Look at X-ray. We'll have clouded, opaque, frosted, or grained glass appearance. Taking a glass and grinding it. Okay? Or sometimes they will describe that as diffuse bilateral infiltrates. What we call that is their X-ray is whited out. So instead of saying that it's whited out, you can say diffuse bilateral infiltrate. There's widespread atelectasis because the lung compliance is very low and nothing is fighting the surface tension. So the alveoli are kind of like pulled in a lot. Patient may be hypothermic, they may be cold. Patient's skin may appear pallor. They look like ashy, very ashy looking color. Muscle tone may be flaccid. Treatment for RDS. We can accelerate lung maturity with glucocorticoids, steroid, surfactant therapy. Surfactant can help increase lung compliance by decreasing surface tension. If the baby has to go on the ventilator, we use higher FiO2s and higher pressures to ventilate them. And now remember that permissible hypocapnia. Permissible hypocapnia is where you're going to accept a blood gas that is slightly acidotic, then continue on to use high PEIP to ventilate the baby, which may then lead to barotrauma. Okay? So we can only go up on the pressure so much. And then if we get to a point where the pressures are going very high, then we need to do permissible hypocapnia. In fact, for a baby, we don't like to exceed a PEIP that is greater than 30. Okay? If you're ventilating a premature baby and the PEIP, including the sum of your PEEP and your PEIP, is going to exceed 30, you need to think about surfactant therapy. Because if you give the surfactants, that will improve their lung compliance and then enable you to use lower pressures to ventilate the baby. We can do a dexamethasone. That's a steroid. That's an IV steroid. A lot of swelling inside the airway when they have that RDS. So steroid can help decrease swelling. We can use diuretics. We'll need to keep the baby warm. Okay? Because if the baby is not warm, they will be using up more of the brain fats that they made during gestation. Okay? Complications of RDS. Most complications are due to the use of positive pressure ventilation. Okay, positive pressure ventilation causes a lot of problems for babies when we have to use it to treat the RDS. Okay? The first thing is intracranial hemorrhage. They can bleed in their brain, okay? Because we rupture a lot of blood vessels as a result of using high pressures to ventilate them. Babies can develop DIC. Now, DIC stands for disseminated intravascular coagulation. Now, DIC is where the baby will lose all the clotting factors. Their blood will become very difficult to clot. Okay? As a result of that, the baby can easily bleed. And when they bleed, they can bleed to death. Okay? They can bleed to death. Mechanical ventilation causes that, especially when you're trying to treat the RDS. They can also develop infection from mechanical ventilation. PDA, okay, patent ductus arteriosus. This is when the ductus arteriosus fails to close at parts as a result of hypoxemia. Now remember, we said that what causes the ductus arteriosus to close is increase in oxygenation when the baby begins to breathe spontaneously. Now the baby is born hypoxic, it will not close. RDS, okay, will cause the baby not to oxygenate well, okay? And if the baby is not oxygenating well, that can also keep the ductus open, okay? So that's a complication of that. The next thing is bronchopulmonary dysplasia. Bronchopulmonary dysplasia. What causes a bronchopulmonary dysplasia is the treatment for RDS, which is mainly like using high pressure and high FiO2. So like once you use high FiO2 and high pressure to treat the baby of RDS, the complication for that is bronchopulmonary dysplasia. Okay? This is like the chronic lung disease for the baby. Okay, you know, like adults get COPD, the way their blood gases look. And so normal blood gas for COPD patient would be that the pH will be in the acceptable range, like that. So when a baby has bronchopulmonary dysplasia and they have this type of blood gas, so it's like the chronic lung disease of the baby. Okay? Causes oxygen toxicity, that oxygen that we're using to treat RDS. Okay? High level of oxygen leads to edema and thickening of alveolar tissues, and the tissues will hemorrhage. So high oxygen will cause that. Barotrauma. Okay, now we're using high pressures to treat the RDS. Okay? So it says that BPD incidence increases with high ventilating pressures. BPD incidence decreases with low ventilating pressures. Presence of presence of PDA, okay, patent ductus arteriosus. Patients develop both CHF and pulmonary congestion, which necessitates the use of high pressure to ventilate. So it's like when they have the PDA, we are going to use higher pressures, which would then cause the baby to develop BPD after the RDS is treated. Fluid overload, neonates with fluid overload have higher incidence of BPD, because fluid overload will probably cause you to use high pressures to ventilate the baby as well. Diagnosis. When they have BPD, X-ray shows grand glass appearance, just like when they have the RDS. But eventually, the baby is going to start forming cysts, okay, inside their lungs. When you look at their X-ray, you see cysts inside the lungs. And so that's the main difference between the X-ray of RDS and the one for BPD. ABG shows chronic lung disease, just like that, the blood gas of a COPD patient. EKG shows right ventricular hypertrophy. They have more muscle on the right side of the heart than they have on the left side. Usually there is more muscle on the left side than you have on the right side, because the left side is bigger than the right side. But the opposite is the case here. Okay, that's ventricular hypertrophy. Lung compliance is decreased. Treatment for BPD, prevention. Okay, you have to kind of monitor the amount of pressure and the FiO2 that you're using to treat the RDS. Okay. High frequency ventilation. High frequency ventilation is where you're going to use very small tidal volume but high respiratory rate. Okay, very small tidal volume but high respiratory rate. In that way, you're not using very, very high PIP to ventilate. Bronchial hygiene such as CPT, okay, and UA, okay, that would help losing secretions. Fluid therapy, we want to make sure we maintain fluid balance. Input and output. Okay, input and output. Usually, output should be greater than input. Okay? When input exceeds output, then baby can retain fluid. Okay, they retain fluid, and then that will necessitate you to use higher pressures to ventilate the baby. Okay? Right heart failure, if there's right heart failure involved, we are going to use digoxin. Digoxin is a drug. It is an inotropic agent that increases the strength of myocardial contractions. It increases the strength of myocardial contractions, increases cardiac output, increases blood pressure, and increases perfusion to organs and tissues. And of course, we have to monitor nutrition, the baby's nutrition. The next thing is retinopathy of prematurity. Okay, that can happen to the baby, and as a result of the baby being given too much oxygen. Okay? The too much oxygen will damage the baby's eyes. Okay, now what we said is that the normal PaO2 for a baby is 50 to 70 millimeters of mercury, no more than 80. But now studies have shown that PaO2 greater than 80 can result in retinopathy of prematurity. Okay, so in essence, if you need to, you can go up to 80, but you cannot go more than 80. So that's what it's saying here. In the presence of high levels of PaO2, the retinal blood vessels constrict, leading to necrosis of the vessels. Okay? It may lead to blindness. The baby can become blind. Okay? Other factors attributed to the development of ROP are early intubation, okay? Necrotizing enterocolitis, they have problem with their intestine, hypotension, and bright lightning in the nursery. Okay? Can cause that as well. So now if you look here, you can see this very well. So what happens in retinopathy of prematurity, you have all these blood vessels beginning to grow very fast and spread everywhere, right here. There's a retina back here. So they're growing this way, at a very rapid rate. Okay, so treatment is based on stopping the spreading of the vessels. You want to stop it from growing from all corners. Okay? So eye exam is a good way to make diagnosis. If you look into the eyes, you can see that the blood vessels are growing at a very rapid, uncontrolled rate. So what we're going to do to prevent that is that we have to stop the blood vessels from growing to all corners of the retina. Okay? This one's here, growing that way. So treatment is prevention of using, you want to use lower FiO2s to get lower PaO2s. Okay? You don't want your PaO2 to be greater than 80. Okay, that's prevention. But you can use a therapy that they call the cryotherapy. So what they do in cryotherapy is that they use a probe that has been cooled down to negative 20 degrees, okay, to freeze the vascular section of the retina. Like right here, this is the vessels growing that way. So here's the retinal vessels. We're going to freeze it right here so that the blood vessels will stop growing towards the back of the retina. Okay, that's what we mean by that. Whoops, sorry about that. Okay, so another therapy is you can use the laser therapy. You are doing the same thing. You want to photocoagulate the vascular portion of the retina. Right here. Photocoagulate so that the blood vessels are not spreading everywhere. Okay? Any questions about retinopathy or prematurity. The next thing is asphyxia. Asphyxia is deprivation of oxygen to the baby. It can occur while the baby is still inside the womb, or maybe during birth, or after birth. Asphyxia is a combination of hypoxia, hypocarbia, and acidosis. So they will have low oxygenation, they'll have high CO2, and then they will be acidic. No matter where asphyxia is taking place, there is a reason for blockage of blood supply to the baby. Remember, the baby gets their blood from the placenta. Okay, so between the placenta and the baby, there is somehow blood flow to it is being obstructed. Causes of asphyxia. Okay, now we look at maternal factors. Okay? Now, the maternal blood replenishes the placenta. Okay? The maternal blood replenishes the placenta. So that means that if the mother is hypoxic, the placenta will also be hypoxic. So that the blood coming from the placenta and is going to go into the baby will not have enough oxygen in it. So things that can cause the maternal blood not to have as much oxygen to replenish the placenta are maternal shock. They have low blood pressure when they have shock. So the placenta may not be replenished as well. The mother has asthma attack. When you have asthma attack, the PaO2 goes down, and that will affect the placenta. Okay? The mother has carbon monoxide poisoning. The carbon monoxide poisoning will prevent the mother's hemoglobin from uptaking oxygen. Okay? Therefore, that affects the baby as well. The mother has anemia, okay? Low hemoglobin. Well, hemoglobin is what carries the oxygen. So if the mother has anemia, then that means that the oxygen delivery to the placenta will also be low. The mother has CHF. CHF causes low blood pressure. Okay? And if the mother has low blood pressure, then the placenta will not be perfused as well. Low ambient oxygen. Okay, they are somewhere where they're not breathing 21% oxygen. Okay, and severe pneumonia. Pneumonia will cause you to have hypoxemia. So anything that causes the mother to be hypoxemic will also cause the placenta to be hypoxemic, and therefore the baby will be hypoxemic. Any questions about maternal factors? It can also be to disruption of uteroplacental blood flow. Okay? Maternal shock, again, will decrease the blood pressure. There is vasoconstriction, okay, of the placenta, no, not the placenta, the umbilical cord. That will also affect it. Okay? There will be reduction in blood flow from that placenta to the baby. It can be due to dysfunction of the placenta itself. The mother may have placenta previa. Placenta previa. This is where the placenta is right there at the cervix. Okay? Right at the cervix, very low at the cervix. That can result to bleeding. It can result to bleeding. And if the mother is bleeding out, that's less blood. That's blood that would have been perfused in the placenta, but now the blood volume is going away. It can be due to abruptio placenta. okay, which is when the placenta prematurely breaks loose from the uterine wall. Okay, it's prematurely peeling out from the uterine wall. A lot of bleeding is also associated with that. So the mother will lose a lot of blood. Consequences of asphyxia. It can lead to primary and secondary apnea for the baby. Now, initially when babies are deprived of oxygen, they will temporarily become apneic. Their heart rate will drop. Okay? But if the baby is stimulated to breathe, you rub their back, they will resume breathing. That's called primary apnea. Not very serious. But now, the baby can also go into secondary apnea from primary apnea. So apnea has gone on for a longer period of time. And when they have secondary apnea, that affects their blood pressure and their color, their skin color, severely. Now, tactile stimulation in the secondary apnea will not result in the baby beginning to breathe again. You have to provide positive pressure ventilation. So when they have secondary apnea, what will cause them to start breathing again is positive pressure ventilation. But when they have primary apnea, tactile stimulation will cause a resumption in spontaneous breathing. Asphyxia can cause hypoxia, ischemic encephalopathy. Okay, that's necrosis of the brain neuron. The brain needs a lot of oxygen. And when oxygen is not provided to it, you can have a lot of neurological deficit. It can cause periventricular leukomalacia, an infarct in the brain ventricle. Okay, scar tissue. Okay? It can cause necrotizing enterocolitis. It can also cause DIC, disseminated intravascular coagulation. Treatment, reversal of hypoxemia. We have to do everything within our power to make sure that the baby is getting more oxygen. If it occurs in the womb, the neonate should be delivered and resuscitated. If we know that the baby doesn't have enough oxygen in the womb, we can go ahead and deliver the baby and resuscitate the baby. Otherwise, it can die in there. Okay? And then we have meconium aspiration syndrome. Meconium aspiration syndrome. Meconium is baby's poop. And there are basically two reasons why a baby can poop in utero. The first thing is hypoxia or asphyxia. If they have asphyxia, they're getting distress and they can poop. And the next thing is that the baby may be too big, maybe bigger than the space inside the womb. Usually, after 42 weeks, first-time babies, they will get in distress. They grow very fast and very big during the last trimester. So if they grow out of the space in there, that can put them in distress. And then they poop. Okay? So meconium is thick, tar-like dark green material that is passed into the amniotic fluid by the fetus, usually due to asphyxia. Okay. The presence of meconium in the amniotic fluid indicates fetal distress. Okay. It is very common in post-term neonates after 42 weeks. So an exam, they tell you that a baby is post-term and they're going to be delivered, you'll be on the lookout to see if the baby will have meconium aspiration syndrome. Okay? In fact, any baby that is going to be born post-term, causes, the healthcare professionals to be ready, okay, for resuscitation because they may have meconium aspiration. Pathogenesis. Asphyxia or other factors lead to the passage of meconium in the amniotic fluid. Fetus, gaps in response to the asphyxia and aspirates meconium. The aspirated meconium causes airway obstruction. And these are the complications that will result from that. Now, there is something called the ball valve effect. Here's the baby's trachea here. And here is the meconium. So the meconium is right there. Anytime the baby breathes in, the airway expands, okay? Because you have all that air coming, the pressure in the trachea will increase, and the trachea widens up like that, a little bit. So the meconium will move further down into the airway during inspiration. And when the baby exhales out, the trachea will rebound and trap it down there, trapping air with it, trapping air distal to it. Okay. Again, the baby breathes again, the trachea expands a little bit, the meconium moves even further down in the airway. And then during the exhalation, it traps it with air. Okay, so that's what's called the ball valve effect. Okay? The meconium moves further in the airway during inspiration. The meconium can cause chemical pneumonitis. Now, pneumonitis is inflammation in the airway as a result of chemical. So the meconium has some chemicals in it. So that can cause swelling inside the airway. There may be vasospasm, vessels wall spasm, and there may be PFC, persistent fetal circulation. Okay, and that is like because of the hypoxemia that will come with this. Okay, the pulmonary vessels will remain the way that they were in utero, constricted in utero. Remember, in utero, they are constricted. Because the baby is going to be hypoxic as a result of the meconium plugging up their airway, they may have persistent fetal circulation. Blood will keep on circulating just like it did in utero. They can have tachycardia and retractions as well. Diagnosis for meconium aspiration syndrome. Evidence of meconium in the amniotic fluid and the fetus aspirated meconium. X-ray will show irregular densities and hyperinflation as the disease progresses. Hyperinflation is as a result of the air trapping. Okay. As the meconium moves further in the airway, it traps air with it each time the baby breathes out. Treatment for that, this area is very important. Treatment is based on whether the baby is vigorous or not vigorous at birth. A baby being vigorous at birth means that the baby has a heart rate that is greater than 100 beats per minute. They have good respiratory rate. Usually, the baby will be crying loudly, crying with vigor, and then the baby has muscle tone. So that's how we determine if the baby is vigorous. So heart rate greater than 100, baby is crying and fussing, okay, and then muscle tone, good muscle tone, okay. So now, when the baby comes out, and you determine that the baby is vigorous by these three things being there, then the baby will not need to be suctioned. The baby will not need to be suctioned. But if the baby is not vigorous, like they have heart rate that is less than 100, they have weak cry or cry without vigor, and they have poor muscle tone, so that would mean that the baby is not vigorous. Then what we have to do is to intubate the baby, okay? And then we'll suction the baby out with what they call the meconium aspirator. Meconium aspirator, okay? We use the ET tube. We actually intubate the baby because I'm going to show you in the lab maybe next week or so. The suction catheter for the baby is very tiny. Meconium is very thick, so it cannot go through that suction catheter. So, but the ET tube, the baby's ET tube, has, a larger diameter than the suction catheter. So we intubate the baby, we hook up the meconium aspirator to it, and then we suction it out, okay? You have to keep on re-intubating the baby, okay, and suctioning them out until you don't see any more meconium in their airway, okay? Even if you have to intubate them several times to do that, you do. So you intubate, you suction, and then you pull the ET tube out with it. And then if you need to suction, you need to re-intubate the baby with another ET tube, and then hook up the meconium aspirator and then suction out. So you use the ET tube as a suction catheter, okay? So that's the way we do that. Initiate mechanical ventilation, CPAP, high-frequency ventilation, or nitric oxide therapy if the condition is very severe. We can do CPT to knock out or knock down the meconium, okay, on the wall of their chest. We can suction the baby if we need to get some more meconium out, okay? So just remember that it used to be that as soon as the baby's head comes out, we can then intubate it there and then start suctioning. But now they don't do that anymore. The new thing is that you have to wait until the entire baby is out, and then you determine whether they have good muscle tone, good heart rate, and they're crying and fussing, good respiratory rate. If they have all those three things, then you don't need to intubate them. But if they don't, what did I say? If they have those three things, you don't need to intubate them. If they don't have it, then it means that they're not vigorous. You have to intubate them with ET tube and suction them out until you don't see any more meconium. Okay? Any questions about that? Biotraumatic diseases. Now, biotrauma is called A-leak syndrome. A-leak syndrome. Now, also, on the exam, if they really want to be funny, they will call it extrapulmonary air. So a lung unit has ruptured, and now you have extra air inside the lungs, extrapulmonary air. Okay? Types of barotrauma. Okay? So again, like if you use high pressure, you have barotrauma. If you use high volume, you have barotrauma. So sometimes you will hear people saying volutrauma or biotrauma. So they're basically the same thing, because the higher your volume, the higher your pressure. Okay? The higher your pressure, the higher your volume. So either way, any of those two names will work. So barotrauma is the damage of the lung unit due to excessive pressure or other factors. Where the air goes after it leaves the alveoli determines the type of barotrauma that will be present. There are different types of barotraumas. The first one is pneumothorax. Pneumothorax is a type of barotrauma. This is where the air leaking out from the ruptured lung unit is going inside the pleural space. It's going inside the pleural space. We have two types of pneumothorax. We have what we call the spontaneous pneumothorax. This is when one or two bubbles of air has moved inside the pleural space. Only one or two bubbles. Not enough to change the pressure inside the pleural space significantly. It's not a very serious type of pneumothorax. The treatment for that is monitoring the patient. You monitor them, you put them on O2 saturation, because it may resolve by itself. Spontaneous pneumothorax can resolve by itself. So you're monitoring the patient, and then if you have to do something about it, you use a chest tube. Chest tube. But most of the time it will resolve by itself. The other one is tension pneumothorax. That is more serious than spontaneous pneumothorax. This is when there is continuous leak of air into the pleural space. Continuous leak of air into the pleural space. Now causing the pressure in the pleural space to rise. Therefore, compressing the lungs. So the patient cannot ventilate well. And since the patient is not going to ventilate well, the patient cannot oxygenate well. Because of the pressure, the patient's blood pressure will bottom out. It's very, very life-threatening. And the treatment for that is nasal aspiration. Or just the compression. Compress. So we have to let the pressure of the chest. So they use like a 20 to 22 gauge needle, and they put it into the pleural space. It goes, right? You let all the pressure of the chest. The patient's lungs will re-expand again. They will start ventilating better, oxygenating better. Their blood pressure will go up now. Because anytime you have too much pressure inside your chest, that affects your venous return. Your blood pressure will go down. Okay? Your blood pressure will go down anytime you have increase in intrathoracic pressure. Even when you're suctioning somebody, okay? Once you begin to suction people, once you insert that catheter, their intrathoracic pressure will go up, and usually the blood pressure will drop to some extent. That's one of the side effects of suction. So just know that it's not in all cases of pneumothorax that you do needle compression. You have to see whether it's tension pneumothorax. Okay? If it's not tension, maybe chest tube. Okay? Diagnosis. Physical signs include tachypnea, fast breathing, bradycardia, retractions, cyanosis, asymmetric chest excursion, change in breath sounds. We don't like to do X-ray on babies. try to minimize, it's not like you can't do it, but we try to minimize that because X-ray can damage their hemoglobin. And then they will have a lot of methemoglobin. Now, methemoglobin is a dysfunctional type of hemoglobin. When you have a lot of it, your oxygen carrying capacity will decrease, just like with the carboxyhemoglobin. So as a result of that, if you suspect that a baby may have pneumothorax, you do what we call trans-elimination of the chest. Remember that, trans-elimination of the chest. Okay? Like I said, it's not like you can do X-ray, but we try to avoid it. Now, trans-elimination of the chest means that they are going to use a fiber optic light, just like this. So let's say that this is the baby's chest here. They use a fiber optic light like the bronchoscope, right? The light that comes from the end of the bronchoscope. They will shine it on top of the baby's thorax. Okay, put it down here, shine it on top of the baby's thorax. And then they look at the halo. They call it the halo. Halo is the silhouette. I don't spell that silhouette very well, but the shadow. That's another name for it. The light shadow. Okay? On the baby's thorax. So if you have a very uniform circle of shadow of the light on top of the baby's chest, that would mean that the baby doesn't have pneumothorax. Very uniform, halo, shadow, whatever you want to call it. But if you have a non-uniform shadow, like that, forming on their chest, that would mean that the baby has pneumothorax. There is a lot of air in their chest that is causing the light to disperse. There's a lot of air inside the chest that is causing the light to disperse at all angles. But for some reason, if you must do X-ray, the best X-ray to do is respiratory. Respiratory film is what you want to do. Respiratory film, because basically we have like 12 ribs, not just 12 ribs. During inspiration, the diaphragm, before you breathe in, is usually at the 6th or the 7th rib. During inspiration, the diaphragm will move down to the 10th rib. Okay? And now when you exhale out, you should come back up to the 6th or the 7th rib. But after the patient has exhaled and the diaphragm is still down there at the 10th rib, that would mean that there is a lot of air inside their chest that is pushing down the diaphragm. So if you find the diaphragm still at the 10th rib, when you shoot the expiratory film, then a lot of air is in there causing the diaphragm to flatten out. Any questions about that? Trans-illumination of the chest. Okay? So you do that before you do the X-ray. Treatment. If minor air leak and patient, observation, if minor air leaks and patient not in distress. Okay? Like they have that as spontaneous pneumothorax. You monitor them, you put start monitoring them, what their O2 saturation, monitor it to see whether it's going to resolve by itself. But if you really have to do anything about it, then you use a chest tube. Okay? And the needle aspiration will be when they have that life-threatening type of pneumothorax, the tension pneumothorax. Okay. Chest tube mostly used if the patient has a continuous leak and is on the ventilator. Okay. So, but now, when you do needle aspiration, you're not done. Okay. Needle aspiration is like emergency, what you're going to do right away. After a needle aspiration, you still have to put in chest tube. I want you to know that. Okay. To make sure that all the air leaves at the porous space. Okay. So with tension pneumothorax, life-threatening, you let the pressure off the chest, and then you put in chest tube. Okay? So that's what we're talking about there. To remove the chest tube, you want to clamp it for 24 hours. Because you're going to do a test to make sure that there's no more of what you are trying to drain with the chest tube. Like air, we're going to put in chest tube. Hemothorax, we're going to put in chest tube. Okay? After 24 hours, there's nothing else coming out, then you have drained everything that you're trying to drain. Okay? How do you pull it out? Okay, well, to pull it out, you're going to tell the patient to do the salvo. Valsalva maneuver. Okay, Valsalva is like trying to exhale out, okay, against an open airway. You go like that. So your stomach is going to push out. Okay? So that helps the tube to come out. When the nurse is trying to pull it out, the patient is doing the Valsalva maneuver, exhaling out against an open airway, so the nurse pulls it out. Okay? And then they will use gauze that on one surface of it you have petroleum jelly, not KY jelly, like Vaseline, petroleum jelly is what you use to cover it. And then you take it out. Okay? Remember that Valsalva. Okay, the patient wants to breathe out against an open airway. And that causes your stomach to move outwards, making it seem to come out with ease.
How do you do that for
Huh?
How do you do that for a baby?
For a baby? Well, unfortunately, babies cannot do it, but adults can do it. Babies can do it, so you just have to go ahead and pull it out. There's no way to do it really in babies. Okay? So this here includes adults. Okay, everything we're talking about here includes adults. Okay, so here's another type of barotrauma. Okay? Pneumomedial sternum. Pneumomedial sternum. This is where the air now that is leaking out from the ruptured lung unit is in the medial sternum area, the central portion of the chest where the heart is, and the blood vessels. Pneumomedial sternum. The treatment for that is chest tube as well. We're going to put chest tube to get that air out. And then we have pneumopericardium. The air is in the pericardial space where the heart is. Pericardial space. Now this one here affects cardiac outputs. It will affect cardiac outputs because it can cause cardiac tamponade. So it's like you have the four chambers of the heart. This is the right ventricle, this is the left ventricle. Well, the left ventricle normally will pump out blood with 120 millimeters of mercury. That's the amount of pressure created in here during contraction. On the right side is 25. So when I have all that air around the left heart like this, and that is creating a pressure level that is greater than 120, it makes it very difficult for this left ventricle to pump out blood. There's more pressure around it. So that's called tamponade of the left heart. When the heart has more pressure around it than it needs to pump out. Now, tamponade of the right heart will be that the pressure will rise, whatever is causing the pressure, the air or fluid or whatever, is creating pressure around it that is greater than 25. Okay? So that's what we got there. That's where cardiac output is going to fall, because cardiac output is the amount of volume pumped out from the heart in 1 minute. And so it will go down because of that pressure. And if your cardiac output goes down, you know what that means. Your blood pressure will go down. If your blood pressure goes down, perfusion to organs and tissues will go down as well. Okay? X-ray is diagnosis for it. And then we have pulmonary interstitial emphysema. Emphysema just means trapped air. That's all it means. Trapped air. That's what emphysema means. Okay? So this is where the air is inside the lung tissues. Okay? The air is inside the lung tissues. So we'll call it the pulmonary interstitial emphysema. Okay? X-ray will show cyst throughout the lung field. Treatment involves the use of low ventilating pressure. Okay, low ventilating pressure. We have air embolism. Now this is where the air will enter the blood vessel. Blood vessel. Now, air embolism is bad. If the air blocks the blood vessel that sends blood to your brain, you can stroke out. If it blocks the blood vessel that sends blood to your heart, you can have heart attack. Okay? But unfortunately, there is not a very good effective treatment for it. Most of the time, the air may just live by itself. Okay? And then we have subcutaneous emphysema. This is also a type of barotrauma. This is where the air that is leaking out from the ruptured lung unit is going under the skin. Okay? It is a sign of barotrauma. Subcutaneous emphysema is a sign of barotrauma, maybe. Something went bad. Okay? It has no treatment. Subcu has no treatment. Okay? Eventually it will go away after the lung tissue heals up. Okay? It's kind of got, it has like a funny feeling. Okay? When you feel on it, spongy, okay, rice crispy. Some people have described it that way too. Okay? It does not hurt the patient, it's not painful. Okay? It's just there. But eventually it will go away. And then we have we have transient tachypnea of the newborn. Transient tachypnea of the newborn. Okay? This will result as a result of accumulation of lung fluid after birth. Babies that are born through cesarean delivery are prone to developing transient tachypnea of the newborn. Okay? Diagnosis of that. the baby is going to have physical signs of respiratory distress, nasal flaring, retractions, grunting. ABG indicates hypoxia because it's like all the fluid, in fact I call it pulmonary edema, all the fluid is inside the alveolus, which would then impair gas exchange. Okay, that's why they have hypoxia. X-ray looks like RDS with streaky infiltrates. You first of all have to rule out pneumonia, because sometimes the X-ray from the TTN looks like X-ray from pneumonia. So you do other things to rule out pneumonia. Treatment for that, humidified oxygen for hypoxemia. CPAP via nasal prongs for refractory hypoxemia. Now, refractory hypoxemia is hypoxemia that is not responding to conventional oxygen therapy. You've gone up to 60% FiO2, but your PaO2 has not come up to the normal range. Then what you're having is refractory hypoxemia. That's another way of saying shunts. It's another way of saying shunts. People who have shunts will have refractory hypoxemia. No matter how much oxygen that you put in their lungs, if their lung units are this way, collapse. No matter how much oxygen that you put in there, it's not going to go anywhere. You have to open it up with PEEP. Bless you. You have to open it up with PEEP. Okay. Increase the surface area for gas diffusion before their PaO2 will go up. If CPAP is unsuccessful, then you're going to use mechanical ventilation. CPT to enhance fluid absorption. Broad spectrum antibiotic because they may develop infection as a result of all the lung fluid down there inside the alveolus. So we have apnea. Apnea is cessation of breathing, okay, for 10 to 20 seconds during sleep. We have two types. We have central or non-obstructive apnea. We have obstructive apnea. These are the causes of central apnea. So what happens during central apnea is the baby will stop breathing, okay, but now when they wake up from their apnea, they don't have increased respiratory effort. They don't make any effort to try to catch up. Okay? It's mainly neurological in origin. Okay? It's supposed to be that anytime the CO2 rises, the central nervous system recognizes that and then sends signal to the diaphragm to contract. So that process somewhere is impaired. It's neurological. Okay? It's not happening. Okay? So it can be due to chemoreceptor insensitivity. They are not sensing a rise in CO2. They are not sensing a decrease in oxygen. They are not sensing a decrease in pH to send the signal to the diaphragm to contract. It can be arousal response. Now usually in the adults, anytime the oxygen goes down or carbon dioxide goes up, an adult patient will wake up as a result of that. But that doesn't happen with babies. Okay? So their system of sensing that high CO2 and low O2 is not very good, like ours. If we have PaO2 drops or carbon dioxide increase, they may not wake up like we do to try to catch up. It can be due to stimulation of airway reflexes. Now, for an adult patient, anytime something goes inside your airway, the normal response is for you to cough. You cough very vigorously to try to expel whatever the material is out of your lungs. That's where we protect our airways. Well, for the babies, instead of them coughing, they go apneic. Anytime something goes into their airway, instead of them trying to cough vigorously to expel it, they will go apneic. It can be due to respiratory center dysfunction. The central nervous system is not working very well to send signal to the diaphragm to contract. It can be due to the respiratory muscles not developing very well, like ours. So these are the causes of central sleep apnea. Treatment for central sleep apnea, anything that can stimulate the central nervous system will be good. Anything that can stimulate the central nervous system will be good. Therefore, we use methylxanthines like theophylline or aminophylline. Theophylline is a respiratory stimulant. It will cause or increase the activity of the central nervous system. We can use IV caffeine. Okay? So both theophylline and caffeine are used to treat apnea of prematurity. When a baby is premature and sometimes they forget to breathe, if you go into the NICU, you can see them on IV caffeine, or maybe they will be on theophylline drip, okay? So that their central nervous system is stimulated at all times. Mechanical ventilation is indicated if apnea leads to respiratory failure. Okay? If the apnea is causing the CO2 to rise, then we're going to ventilate the baby. Obstructive apnea. Okay? So with obstructive apnea, the patient goes apneic, and then when they wake up from apnea, they will have increased respiratory effort. They will gasp for breaths. Usually an adult patient will wake up and then sit on their bed and kind of bend like this and then gasp for breaths to try to catch up with their hypoxemia. Okay? So that's the main difference between central and obstructive. Obstructive, there will be increased respiratory effort when awaking from sleep. And then for central, there is no increase in respiratory effort. These are the things that will cause obstructive sleep apnea. Patient has enlarged adenoid tissues. They have tonsils, their tonsils can cause it block airflow into their lungs, facial anomalies, obesity, and short neck. Obesity and short neck are called Pickwickian syndrome. Pickwickian syndrome will predispose a patient to getting obstructive sleep apnea. But you don't really have to be obese or have short neck to have obstructive sleep apnea. You can be very emaciated and still have obstructive sleep apnea. But those two definitely will predispose you to getting it. Treatment, antihistamine, decongestants, cromolyn sodium, steroids may increase the diameter of the airway, okay, and will cause air to get around the obstruction. They can have surgery. The surgery is to remove the offending tissues. You have surgery to remove the offending tissues. They can remove some of the adenoid tissues, they can remove your tonsil, they can remove your uvula, okay, just to create a space for the air to go in without obstruction when you sleep. Because usually what happens is that once you go to sleep, the muscle tone of all the tissues in the upper airway, they lose their tone. All those tissues will lose their tone, and then causes them to kind of like fall in, collapse, okay, and obstruct the airway. Okay. Now, that surgery is called uvulo palatal pharyngeal plastic. Long name, uvulo palatal pharyngeal plastic. Is done to remove the offending tissues. They may remove your uvula, your tonsil, kind of trim the adenoid tissues. When you have that surgery, maybe 50%, you can decrease obstruction by 50%. It's not 100%. It's a very painful surgery. If you have this surgery, by in 1 week, you still have not eaten. Okay, you eat like a kilo. Okay, for 1 week. It's very painful. You can't swallow. Okay. Now we have CPAP. CPAP is another treatment. CPAP use the pressure to spleen the airway, kind of move the tissues out of the way. Okay, whether at night or during sleep. Okay. Some patients may need oxygen with it. Some patients may hook oxygen with their CPAP. Okay, if they're having hypoxemia, severe hypoxemia when they go apneic, then the doctor may order for you to connect oxygen, maybe 1 or 2 liters or even 3, okay, while you're wearing your CPAP. Okay. Tracheostomy is the best treatment for it, but rare treatment for it. Okay, because you're gonna have a hole poke into your neck. Okay, you poke a hole into your neck, and then that becomes your airway. Okay, you breathe in from there, and then you breathe out from there. But now, bypassing the upper airway means that the air that you're breathing in is not going to be humidified. It's not going to be filtered well. Okay, it's not going to warm as well because the nose is responsible for humidifying, filtering, and warming the air that we breathe. So now you bypass it. So usually what we do is they have tracheostomy, we're going to give them humidity. We use a trachea. Okay? Make sure that they're getting warmed. The air is warm, okay, not very cold with it, when they go to sleep. Okay? And then during the day, when they're awake, they may remove it. Okay? They may do fine, but during sleep, when they're not in control of their breathing, they have to have it over the tracheostomy. Do I have time for this one? This is the last one on that slide, right? Let me go ahead and finish it. Persistent pulmonary hypertension of the newborn. Very common question in the test. Before even I start, the treatment for this is nitric oxide. When they give you this, it's a nitric oxide. It's always on the test. Persistent pulmonary hypertension of the newborn. What does that mean? Well, what it means is that after the baby is born, the baby's blood is still circulating the way, in the baby, the way it did in utero. That's what it means. The baby's blood is still circulating the way it did in utero. Okay? It occurs more in term and post-term neonates with asphyxia. You see now, asphyxia is what is going to cause the shunt not to close. There is persistent pulmonary vasoconstriction resulting in decreased blood flow to the lungs, right-sided pressure rise above left-sided pressure, just as it did in utero. The fetal shunts are patent. The ductus arteriosus will not close. The foramen ovale will not close afterwards. Diagnosis: how do we know that the baby has persistent pulmonary hypertension of the newborn? Okay, we're going to let the baby breathe 100% oxygen for 5 to 10 minutes. If PaO2 is less than 100 millimeter of mercury, then there is right to left shunts, meaning that they will have it. Because remember, in the baby now, the right side pressure is higher than the left side pressure. So all the blood on the right side may be pushed over through the foramen valley to the left side. That's what we mean by right to left shunts. Okay? Oxygen is supposed to be a good vasodilator. Oxygen is a good vasodilator. So if a patient is breathing 100% oxygen, okay, but their pulmonary capillaries are not dilating, then there's a problem. Okay? Because if their pulmonary vessels are dilating, then their PaO2 ought to be increasing. The next thing that we can do to confirm that is comparison between preductal and postductal PaO2. Now, preductal means the blood flow before it goes across the ductus arteriosus. That's what preductal means. And postductal means the blood flow after the blood goes across the ductus arteriosus. So we can compare both of them. Okay. The preductal PaO2 is usually higher than the postductal PaO2. Okay. So what we're going to do then is we're going to measure the PaO2 from right hand. Right hand is preductal. We'll draw blood from the right hand. We'll run it. We'll look at the PaO2. And then we draw blood from the umbilical arterial catheter right here in the stomach or somewhere down on their leg, okay, and run it. Okay. If the patient doesn't have patent ductus arteriosus, the two PaO2s will be the same. They will be the same. Okay. But if the patient has ductus arteriosus, then the preductal PaO2 will be about 15 to 20 points higher than the postductal PaO2. If that happens, we know that the baby has patent ductus arteriosus. Or if you don't want to draw blood gas, you can check their O2 saturation. Put the pulse ox on their right hand and then see what the O2 saturation is, and then you put it on their leg. Okay, that will be postductal. And then you compare the saturation. If it is 15 points greater, then the baby has patent ductus arteriosus. The next thing that we can do to diagnose that is what they call the hyperoxia hyperventilation test. Low CO2 is a vasoconstrictor. Oh, excuse me. Low CO2 is a vasodilator inside the lungs. Okay. Low CO2 is a vasodilator inside the lungs. Now remember, it's supposed to be that the pulmonary capillaries are constricted. So we get the baby, we start bagging the baby, okay, ventilating them, and then send their CO2 way down to 20 to 25 millimeter of mercury, okay, and their pH to like greater than 7.50. Okay. So by doing that, you cause vasodilation, and the PaO2 should increase because now the pulmonary vessels are opened up as a result of the vasodilation. Okay, so if their PaO2 increases to above 100 millimeter of mercury, that confirms persistent pulmonary hypertension of the newborn. By far, the hyperoxia hyperventilation test is the most or the best dependable test. Okay? We can use echocardiogram. We can do echo. Then we look at the ventricles. We look whether there is right to left shunt, see blood flowing from the right side to the left side across the foramen valley. We look at tricuspid valve regurgitation, whether blood is flowing back from the right ventricle back into the right atrium. Okay? And then increased pulmonary artery pressures. Treatment for that, mechanical ventilation therapy. We can keep the baby hyperventilated so that the pulmonary vessels will remain open so that there will be increased blood flow into the lungs, blood that has oxygen in it. We're going to maintain PaO2 levels at more than 100 millimeters of mercury. That keeps the pulmonary capillaries open. Nitric oxide, you want to remember that. Nitric oxide, okay, for PPA. We can give a vasodilator. The vasodilator also will open up the diameter of the blood vessels. And there's one called the tolozolene. Tolozolene is a vasodilator. We can use high frequency ventilation, nitric oxide, or have that twice. Sildenafil is Viagra. Viagra is a vasodilator. It's nitrate. Okay, so it will do what nitric oxide is doing, opening up the vessels. We can use nitroprusside sodium. That's also a vasodilator. That will vasodilate the pulmonary vessels. ECMO is like the last result. ECMO is, we're going to cover ECMO sometime this week. But ECMO stands for extracorporeal membrane oxygen. Extracorporeal membrane oxygen. Basically, what you do with echo is anything, you've tried everything else to oxygenate the baby, and it's not working. So ECMO is like you draw blood out of the baby, and then you run it to an artificial oxygenator. You oxygenate the blood outside the baby's body, and then you run it back into the baby. Kind of like dialysis, right? Because you draw blood from a dialysis patient, get it out of their body, you run it through an artificial kidney, clean it, and then you run it back into their body. So with ECMO, you are drawing it out, you run it through an artificial oxygenator, and then you run it back into the baby. Okay. A lot of complications are associated with ECMO. Not everybody will go on ECMO unless we have tried everything possible to oxygenate you, and you're not oxygenated. All right, so let's take a break.